surface supplying for lower load. Okay. So the most important now come to the interpretation is how do we do for CT chest. So if you are looking at the lung window, you will find the lung pathology, airway pathology, lung parenchymal disease as well. Soft tissue window में you will be seeing mediastinal structure like heart, thyroid, muscles, lymph node, and bony window you will find out any rift fracture. Approach is always like every approach, like you approach for reading a chest X-ray, CT chest, CT abdomen, always you have to review with the full patient history and examine before reading any CT film. So check the patient characteristic which is matching those of your patient. We can miss like the windows we have seen here. The windows, the lungs clearly visible. These are the soft tissues less visible. And here this is a soft tissue window. Here you will have a soft tissues more visible, and this is a bony window. You will have it will be there. You will be looking like lungs में air है, airway में air है. B for bone, C for cardiac and great vessels, D for digestive, E for extra, S for soft tissues. Okay. So air means airway. You will see airway is patent or not, because airway is having air, and if so ground glass opacities means we will be having in these pathologies. But how does it look like in this film? How will you identify? I think you can see this what we will have in the CT chest. Okay, this is the dependent region. Okay, these both are dependent region. You can see dependent region, there is a consolidation because it is having an air bronchogram present. This air bronchogram, this here is air bronchogram. Okay, along with this opacity, there is a ground glass opacity also there. Here. So in the dependent region, you will have a parenchymal consolidation. Developed, okay, my patient, this is having a hilar opacity, okay, the vessels are not looking. So at this point, the parenchymal opacity, so it is a pneumothorax. Okay. Miss, in the emergency, okay, apart from taking right BP, left hand BP and all, if you do CT chest also, if you are not looking properly also, you will look at the lung for pneumonia, pneumothorax and all. Okay, you will send TROP-I CKMB for ACS window, because we can see the soft tissues structure very nicely. Okay, see pericardial effusion like this along with the pleural. Now come to the trauma. Okay, patient come to you, trauma. RTA with head injury and polytrauma with long bone fractures as well as blunt chest trauma. So in that you will do a CT trauma protocol. CT trauma protocol, CT head होगा, CT chest होगा, pelvis abdomen होगा, neck होगा. So I am telling you about the CT chest. CT chest में क्या क्या मिल सकता है हमको trauma में. What all pneumothorax we have seen? The three findings which we have all discussed. Now turn is yours. You have to tell me the three abnormalities in this CT chest film. Yes? Yes, very good. Bilateral pleural effusion. Tell properly bilateral pleural effusion. Okay. Right more than left. Very good. Next. This is first abnormality. Second is fracture of the transverse process of the vertebra, which we can miss. Usually we don't see. We see only big structures. But if you follow the mnemonic A, B, C, D, E, don't forget to look at the bones like this. Okay? Anybody can miss. we will be looking like this. Okay, this is a effusion is there. Let finish. Call the surgeon. Put ICD. Finish. Okay. And most important thing is one more thing we are missing. This arrow. What is this? What is this? What is this called? Actually, this is whole is mediastinum. So hemomediastinum is there. So we can miss that also. Okay. So three things I asked you. This is pleural effusion. This is the fracture of the transverse process. One is this hemomediastinum. Along with, you can see this. There is a separation of this pleura. Okay. Parietal pleura, visceral pleura. Okay. There is this thing. Slit is there. So this is dividing mediastinum. So hemomediastinum also you should not forget. So we are looking the CT slides of trauma patient. So what is this next trauma? Contusion. We can, if there is a lung opacities are there like this, so it will be a lung contusion. Most of the lung contusion they occur at the periphery because the peripheral vessels they rupture and they develop some effusion as well as contusion. So contusion will look like this hazy opacity in the CT chest. Okay. What is this? This coronal view of the trauma patient, blunt trauma chest. Identify the two abnormalities in this coronal view. Diaphragmatic rupture on the left side, abdominal content reaching onto the left lung and causing the Can you see this? What is this sign? Dr. Rajesh will tell in the X-ray, because this looks like an X-ray coronal view. So you will have a word with the Dr. Rajesh. It is a pneumothorax as well. The sign sir will tell you. Okay, just wait for some time. So now come to the last part of my topic is CT pulmonary angiogram. Okay, CT pulmonary angiogram very important. We order every time. My patient, post-op patient, or post-CABG patient, post-ortho surgery patient, day 3 or day 4 of ward or a hospital administration. Now my patient is having a desaturation, 80% saturation, and even with the 10 liter of oxygen, he is maintaining only 92%. What happened suddenly to him? So surgeon call intensivist. Okay, can you please see my patient? What is happening? Okay, we will ask, have you given any prophylactic measures? Okay, we have given this, but despite of that, patient is having these complaints. We will examine the legs, whether any DVT developed or not. Okay, we will admit the patient to the ICU, we will measure the vitals, we'll see the blood pressure. Okay, blood pressure. Now the blood pressure is showing only 80. Patient is showing blood pressure 80, means patient is hemodynamically compromised. What immediately you will do? What is the immediate suspicion in your mind? Patient post-orthopedic surgery. Okay, so only thing is pulmonary embolism. We will think of pulmonary embolism. We will order CT pulmonary angiogram immediately if we having the facility in-house or out of hospital. Okay, with the initial blood test like D-dimer test. Machine is not available, but you can send patient for CT pulmonary angiogram, or if you are in a hospital having compared to other modalities, and it is diagnosing up to the subsegmental and segmental levels. So important is segmental and subsegmental, because Because if patient is having desaturation but without any hemodynamic compromise, so you can diagnose, okay, my patient is having a pulmonary thromboembolism but not massive kind of pulmonary thromboembolism. I can manage with anticoagulation without thrombolysis. So, identifying subsegmental artery thrombosis and segmental artery thrombosis by seeing this CT chest, I will show you how we can see the segmental and segmental artery thrombosis. So there is one term called motion artifact. You all should know what is motion artifact, because अगर आपका technician skilled नहीं है और उसने properly CT pulmonary angiogram नहीं लिया है, because it needs breath holding to take this angiogram. So then there is a misdiagnosis or indeterminate CT pulmonary angiogram. The finding will be like there is no pulmonary angiogram, or if there is no pulmonary embolism, we might tell them there is a thromboembolism with this artifact. So how it develops? Due to rapid change in position of the vessels on the contiguous images, and radiologist can easily identify if there is a motion artifact. So he will be very careful while making diagnosis of pulmonary thrombolism if it has happened. How can we reduce it? This motion artifact, holding breaths. So there is a 16 slice MDCT and versus 64. If there is a thrombosis in the lobe, you can see the density of the dye here and here at the end, and here it is an attenuation. So it is a confirmation there. There is an attenuation or interruption of the flow of contrast material. So it is a thrombosis of the pulmonary artery. Okay. What are the direct signs? Both acute and chronic pulmonary emboli are identified as the intraliminal filling defect. The term is called filling defect in CT pulmonary angiogram. If filling defect is there, the artery will be expanded, enlarged. Second is central arterial filling defect रहेगा. उसके surround में contrast material रहेगा. How it looks like in a film, I will show you. Okay. So this is a CT chest having a subsegmental thrombosis. Can you see this thrombosis subsegmental? It will be compared on the other side. I told you the thrombosis जहाँ जिस artery में होगी subsegmental में, that artery diameter will be dilated or there is an expansion of that artery. So we will compare this artery to that artery from the other side. There is a dilatation, or so we can diagnose this at subsegmental levels. Okay, that is important. Subsegmental, segmental levels. Like here also. यहाँ पे center में thrombus है, but surround में dye can easily visible. So this, I told you earlier, how can you measure the severity? Severity means measure the right ventricular wall diameter to left ventricular wall diameter. We will calculate the ratio of the right ventricular to left. 20%, 1.9, 30%, 2.1, and 2.3 is up to 50% chance of death. So you can tell the relatives that patient is having that much chance of grave prognosis with that CT scan finding. So how it will look like this? You have measured the diameter, short axis diameter of the right ventricle. This is, we have seen in the ventricular region in the beginning of the CT film. So this is the right ventricle. We have measured the axial short axis diameter. It is 5.2 centimeter. This left ventricular short axis diameter is 3.2 centimeter. So ratio is 1.6. So ratio is more than 1, which means patient is having a severe pulmonary thromboembolism. Okay, what is this? This is a term called, anyone? Loudly. Very good. Saddle thrombus. This is called saddle thrombus. Saddle thrombus occurs at the bifurcation of the pulmonary trunk. This is the main pulmonary trunk. This is right pulmonary trunk, left pulmonary trunk. So जो thrombus है यहाँ आके अटक गया है, but it is not